Hello, my name is Kevin Zayas, and I am presenting When the Lung Will Not Re-Expand, Trapped Lung and Pneumothorax ex vacuo following drainage of a massive pleural effusion. This case highlights an unrecognized cause of persistent hydropneumothorax after the pleural drainage and illustrates the importance of distinguishing pneumothorax ex vacuo from an ongoing air leak. Trapped lung is a form of non-expandable lung caused by chronic visceral pleural restriction. Following pleural drainage, the affected lung may fail to re-expand, resulting in pneumothorax as vacuo. This entity is often mistaken for a persistent air leak or procedural complication, leading to unnecessary interventions. Despite being reported in up to 20% of therapeutic drascentesis, trapped lung remains unrecognized in clinical practice. The patient was a 66-year-old female with end-stage renal disease on chronic peritoneal dialysis and a history of failed renal transplant. She presented with progressive weakness after missing multiple dialysis sessions. Initial imaging demonstrated a massive right pleural effusion with near-complete compressive collapse of the right lung. A right-sided chest tube was placed and drained more than 1 liter of pleural fluid. Despite successful drainage, the patient developed persistent hydropneumothorax with continued failure of right lung re-expansion. Bronchoscopy was performed and was negative for endobronchial obstruction. CT imaging demonstrated pleural rind formation and visceral pleural thickening. Based on serial imaging and clinical evaluation, the diagnosis of trapped lung with pneumothorax ex vacuo was established. The center of the poster demonstrates the evolution of the patient's disease process. Panel A, obtained on June 20th, shows a massive right pleural effusion with near-complete compressive collapse of the right lung. Moving on to Panel B, obtained on June 22nd, after drainage, a hydropneumothorax is present. Although fluid was successfully evacuated, the right lung remained contracted and failed to re-expand. Panel C, obtained on June 28, demonstrates persistent non-expandable lung despite ongoing drainage. At this point, the primary problem was no longer the pleural fluid itself, but rather the inability of the lung to re-expand because of chronic pleural restriction. Finally, Panel D, obtained on July 1st, shows persistent pneumothorax ex vacuo despite successful evacuation of pleural fluid. The persistent pleural airspace reflects loss of pleural opposition caused by a trapped lung rather than an active air leak. This serial imaging progression represents the key teaching aspect of the case. Several findings supported the diagnosis of trapped lung. This included persistent hydropneumothorax, failure of lung re-expansion, and pleural rind, as well as visceral pleural thickening on CT imaging, and a negative bronchoscopy excluding endobronchial obstruction. Importantly, this presentation should not be mistaken for a bronchopleural fistula or ongoing air leak. In trapped lung, the persistent pneumothorax results from loss of pleural opposition between the lung and the chest wall rather than continued leakage of air from the lung itself. Recognition of this distinction is critical because additional pleural interventions may provide little benefit once the diagnosis has been established. Continued drainage failed to achieve lung re-expansion. Given the patient's fertility, significant comorbidities, and preference to avoid surgical intervention, conservative management was recommended. There are 5 major teaching points from this case. First, persistent pneumothorax after pleural drainage is not always an air leak. Second, failure of lung re-expansion should raise suspicion for trapped lung. And thirdly, pleural rind and visceral pleural thickening support the diagnosis. Another point, fourth, pneumothorax ex vacuo does not necessarily require additional pleural intervention. And finally, early recognition can prevent unnecessary procedures and prolonged drainage. In conclusion, persistent hydropneumothorax after pleural drainage should prompt consideration of trapped lung and pneumothorax ex vacuo. Recognition of failure of lung re-expansion as a manifestation of non-expandable lung can help avoid unnecessary interventions, guide conservative management, and identify patients who may benefit from definite therapies when clinically appropriate. Thank you for your time and consideration.